Thank you so much for being here with us for our first meeting of 2024. We have three great presenters with us. Excuse me, four great presenters. So um, I'm going to get to all of that in a minute, but I do have some semi-good news. As everybody knows who's regularly here, we begin every meeting by taking a look at where we stand, what we've seen over the month since our last meeting. And as you recall, and again, obviously keeping in mind that we fully recognize that any one death from an overdose is too many. But I talked in December about the fact that we seem to be on track for a good decline from the 2022 numbers. And now that we have wrapped up 2023, I can report that that decline held. And in fact, we are at a flat 20% decline, which is huge. And for those of you who've been with us from the beginning, folks like Rita and some of our folks who've been here the whole time, when we just couldn't turn the tide. And no matter what we were doing, the numbers kept going up. To be at a 20% decline is enormous. And to make that a little bit more personal, that 20% is 45 people. So that's 45 people who didn't have the fate of dying from an overdose, as well as, we always say keeping that number at 10 of how many people might be affected, that being a small number. That's 450 people and family members and friends who didn't suffer that kind of a loss. And, that work is really due to all of you. So many of you on this call are out there fighting the good fight all day and sometimes all night. And that, and I say this all the time, that is really what has made the difference here in Middlesex. When you look at the statewide numbers and the national numbers, they're not going in that direction. So that is not to say there is not more work to be done, because this month in January, tragically, we have already seen 10 deaths as well as 2 suicides with the use of opioids. And remember, we're only counting something as a suicide when it is absolutely clear that that's what it is. There are notes, people have made statements. So we recognize fully that there may be others that we don't count of that. But I have to say, I am feeling pretty recharged about that, seeing that significant decline. And yet, many of you know, and some of you were with us, I recently hosted our annual convening of the police chiefs, the fire chiefs, and the superintendents of schools. And we had a number of wonderful speakers, including former Boston Police Commissioner and a great friend of this office, Ed Davis. We had Special Agent Sarah Whedon, who many of you have seen from the FBI, and Dr. Robert Segi from Tufts Medical Center. And we talked about 2 critical and interrelated topics, and that was swatting, just the phenomenon of swatting, which if you didn't see, and to talk about how pervasive that is. About a week and a half ago, the White House, where we would hope that security is pretty good, was the subject of a swatting incident. A call was placed that there was a fire on the White House compound and that people were trapped inside. So you can imagine when the DC police and fire get a call like that, what the response looks like. And of course, it was fake. And in addition to swatting, that we are seeing just in incredible numbers. On one day here, we had 28 school districts that got swatting calls. But in addition and related, we also talked about youth mental health. And my message then, which really is the same as today, is that really the word of the moment is urgency, the need to address so many of these things. I think this is a pivotal moment, as everybody who's paying any attention to what's going on, and regardless of your politics, the next 10 months promise to be a roller coaster. The kind of rhetoric that's out there, the violence we've already seen and the potential for that. We just really have to be on top of that, whether it's the opioid epidemic, the achievement gaps that we've seen in cross sections. If you haven't read it, I commend to people because it's truly concerning. The series the Boston Globe just did about literacy, that here in Massachusetts, where we pride ourselves on education and literacy, the enormous number of kids, even in the most affluent suburbs, who cannot read beyond a third grade level. So think about that as we think about information that we're getting out there. And, you know, again, our work is cut out for us, but I am, as I always am, incredibly grateful and optimistic because of all of you and the work that you are doing and the results that we are seeing. I will tell you my goal for this year is to see that same reduction, another 45 people. That would get us, for the first time in almost a decade, below 150 deaths. I think that's very attainable with your help. Obviously, there are some pieces that are out of our control, but I think that we have shown that this cross-sectional, multidisciplinary approach really brings great results. So I am looking forward to that. And again, I mentioned our suicide numbers. Last year in 2023, we had 16 clearly suicide deaths. That number in 2022 was 6. So, and as I mentioned, we've already had 2 this month. So one thing that I would like people to think about, and we will talk about this next month, but I would hope that people would come with ideas, is what you are seeing in your work about this uptick and ideas you have for how we can be proactive. Obviously, this is a national problem, but we are feeling it pretty acutely right here. So just a little background for our guests today and people who may be here for the first time. This incredible task force that I am talking about, we began in 2012 when we first saw an uptick, and it was a very dramatic uptick in opioid deaths across the county. And I know I did not, as I'm guessing many of you on this call did not know a whole lot about opioids. And we decided that we would treat this as a public health issue, in addition to being a law enforcement problem. And we decided to bring together people from every discipline, and we made a very conscious decision that we would seat these task forces in our hospitals, not at the police station, to emphasize that community and public health approach. And it was so successful when we began it up in Lowell. And I say this all the time too, Lowell deserved a lot of credit for, at a time when there was so much stigma, even more than now, for being willing to take this problem on. That was so successful that we expanded it to 5 other of our hospitals. We have met once a month, every month since then, even through the pandemic. And we, during the pandemic, decided to go virtual and bring all of our task forces together. We used to be in kind of this round robin where we'd ask the same speaker to do 3 or 4 of the same presentations. So this has made us really much more intentional and given us a lot more opportunity to share information. Over the last year, we've had some really amazing speakers. The director of the BU School of Public Health's new Center on Trauma and Medicine. We have had presentations from our own task force members. We've had a member of the White House Office of National Drug Control Policy talk about what the White House was doing to combat the threat posed by xylazine. We've heard some really cutting edge work and intersecting issues, such as from Dr. Caleb Dresser, the Director of Healthcare Solutions at the Chan School of Public Health, and from a professor at Tufts, Dr. Shakira Shrestha, on spike detection protocol and disseminating spike alerts. I just noticed we have a question, I guess, about what is our suicide rate per 100,000. Our population is 1.8 million. So if you can back that number out and do it to 100,000, that gives you what's consistent with everybody else. So I'm going to turn it over to our presenters, but I just want to remind you, and I will do this again at the end, we continue to offer Narcan for anybody who needs it. You may have seen this week, again, some people still having trouble at pharmacies getting Narcan. We are also offering fentanyl test strips, the same that the state does through DPH. And we have already distributed over 4,000 xylazine strips. So we have another big shipment of those coming. I don't want them on the shelf. I am happy to make them available to you. So we'll do some updates at the end, but I want to begin by introducing our guest speakers. And we are going to start with Cheryl Savara, the Executive Director and Senior Staff Attorney at the Massachusetts Association of Health Boards, who's going to talk to us about the opioid settlement, appropriation, and distribution. And as is the case with another one of our speakers today, it was folks on our task force who brought them to our attention. I want to thank Mike Hugo, recommending that we have Cheryl come join us. And many of you have probably been reading a lot about the settlement, the opioid settlement that's coming. People are making lots of plans for how to spend that money. And I'm going to turn it over to Cheryl, her presentation, who I know is also going to be willing to either take questions at the end or answer the questions that you can put in the chat. So Cheryl, thanks so much for being with us and this welcome news of that there's going to be money out there to help us with this work. So thank you.
Thank you. I am going to try to share my screen. Can everyone see that? This is the first time I've successfully shared my screen in 3 years. So that in and of itself
That is an incredible accomplishment.
That is truly an accomplishment for me. Thank you very much for having me and allowing me to share some of the work that the Massachusetts Association of Health Boards has been partnering with the Department of Public Health, the AG's office, and JSI. We are a not-for-profit membership association. We provide legal education and technical assistance to the 351 local boards of health in Massachusetts, all of whom have the legal authority to enact local public health laws. Just a quick disclaimer. Well, why don't I put this in slideshow mode? We do not provide legal advice. We only provide legal education. City and town attorneys provide legal advice to the city and town attorneys. We're happy to work with city and town attorneys. We do that frequently, especially in some of the work that I'm going to be sharing with you. So just a brief background on how we got to be where we are today. And I know I'm talking to people that know this probably even better than I do, but just briefly, our Attorney General Healy at the time and others throughout the United States have been and continue to settle litigation claims against the manufacturers, distributors, and retailers of opioids for their role in contributing to the devastation that we are facing right now. It's good to hear that deaths are going down, but we are still experiencing an epidemic, as we all know. And the key findings from the AG's investigation against manufacturers is that they used unfair and deceptive sales tactics to aggressively promote these prescription opioids. And the numbers really bear this out, that a large part of this problem was from aggressively promoting prescription opioids. And then the distributors they were negligent in monitoring systems. They ignored red flags and they shipped suspicious orders even when they knew the orders were suspicious to pharmacies. And these are violations of the Consumer Protection Act, as well as just civil torts here. And then the pharmacies dispense these pure negligence, with not really caring about whether the prescription was legitimate or not. So, and as a result, and this slide sort of bears out what I just said, more than 68% of the filled prescriptions for opioids were written by prescribers. So that's 68% of opioid-related overdoses were from prescriptions. So in all, it's anticipated that Massachusetts will receive more than $900 million in abatement funds. And the terms of these settlements, well, some of them have their own nuances, but in general, and this is across the board, 40% of the funds are going directly to municipalities, and they're to be spent on specific evidence-based strategies that we're going to talk about. And those strategies were developed by the Opioid Recovery Remediation Fund Advisory Council, affectionately referred to as ORF. 60% of the funds go to ORF, and they're directly designed to supplement prevention efforts, and this is supplement, not supplant, to supplement prevention efforts that are currently going on, harm reduction, treatment, recovery programs throughout the Commonwealth. This is not a Metro West, urban, Boston-centric program. This is throughout the Commonwealth. And the ORF Council is overseen by the Executive Office of Health and Human Services. And the council is made up of 10 municipal appointees, 10 state appointees, all of whom have experience and expertise relative to opioid use disorder. You can go right on to their webpage and see who the members are. They meet at least 4 times a year. The meetings are open meetings. Anyone is able to attend. Here are some of the defendants that are paying legal settlements, and you recognize most, if not all, of them. Um, and this is the guiding principles for actually using this money can really be summarized in this slide. And this is from the Johns Hopkins School of Public Health. And I really like the way that they've summarized it. And this is a summary for the entire nation. But if you keep these guiding principles in mind when you're looking at, or when your municipal officials are looking at strategies, and hopefully they're not looking at strategies in a vacuum, they're doing the community engagement that's necessary in order to create and implement strategies. We're there to say the money should be saving lives. And again, we're supplementing existing spending. We're not replacing it. And this is sometimes a hard sell to municipalities that are looking for ways to operate more efficiently and to really look at how they build their budget, trying to look at ways to save money. This is not the program to do that. This is a program that is designed to supplement what's already being spent on good opioid prevention strategies. And we want to use our evidence in order to guide what we do. We want to use some of the lessons learned that we have learned in Massachusetts when we had huge tobacco control programs. And there is a piece of prevention, a very important piece of prevention, but we want to make sure that the prevention work that we're doing is evidence-based. It's not buying stuff that says don't use tobacco. And these are some of the lessons we learned in our initial 20 years ago tobacco control prevention efforts, where, bringing in a guest speaker who gives away things isn't necessarily an evidence-based strategy. You really want to look at what are evidence-based strategies in prevention. The focus should always be on health equity and racial equity. We have lots of evidence, and you folks know better than I do, the the uneven way that people of color frequently do not have access to treatment opportunities. Sometimes it's because of no transportation or being unhoused or just not being able to get the services. Some places in Western Mass, they're just too far away from where people live. So these are some of the overriding principles. And one of the most important ones is the last one on here, is that we need to be transparent when we're deciding how to use these.
Millions of dollars will go
And
towards
we want to actively engage with people who use drugs, with people who have lived experience with opioid use, with clinicians, and with public health professionals. We want to integrate all of these partners, as well as our police and fire. So what has happened is CARE Massachusetts, which I'm sure many of you are familiar with, is the name of the Massachusetts Opioid Abatement Partnership. And JSI is really the the main TA provider. They're really driving the bus in providing TA to cities and towns and to other partners. They clearly work in partnership with the Bureau of Substance Addiction Services at the Department of Public Health and with the AG's office. But they, their website is really comprehensive and has a wealth of information that's really helpful, including how much money each municipality has, how much they're getting, when they're getting it. And it's a really helpful website for learning. And here are, they're receiving TA requests from various folks throughout, excuse me, the Commonwealth. And these are just some of the requests and the areas that they are providing technical assistance, and also through MAHB, some legal education in. So some of the community partners are listed here, not all of them, of course, but some of them. And MAHB, our agency, has recently joined Massachusetts Cares as one of the partners. They will welcome any and all, and they're happy to really if you reach out to them, they are more than happy to reach back out to you. So here are the approved by ORF specific municipal abatement strategies. And again, they encompass those 5 principles that I mentioned previously. So I'm not going to go through all of these because you've already heard me say them. I'm just going to mention some that weren't in the initial slide. So addressing needs of justice-involved people is a really important goal and an important strategy. And supporting pregnant and parenting individuals and their parents, including infants that suffer from neonatal abstinence syndrome. And, the implementing prevention education, and I would add implementing prevention policies, some of which we looked at when or that we always look at when we're looking at tobacco control strategies. There may be some local Board of Health policy strategies that we can look at as a means of implementing prevention efforts. So there are reporting requirements for this money, and they are overseen by the Office of the Attorney General, and they are requirements for any city or town that's receiving a total amount of payments of 35,000 or more, which includes many. Even if a municipality is receiving less, they are encouraged to report, because this is how we can assure that the money is being used for the purposes for which it is intended. Municipalities are encouraged to work together to pool resources, And this is happening in Western Mass and some of the smaller municipalities that are really looking to existing recovery programs that are evidence-based, that have positive outcomes, and they're looking at adding the capacity to some of these programs to do more work. And we are also looking at what many of you, I believe in Middlesex County, it's almost all of the municipalities are now members of a public excellence grant. And we'll speak a little bit about that, but these grants are managed through the Office of Local and Regional Health and at DPH, and that office is also able to provide some guidance for how to pool these resources and how to get services out to residents. And if you want to register, there's a portal at caremass.org where you can get on their mailing list and get some information. And again, as I said, you can access these expenditure reports on CareMass's dashboard. Um, so how do we get these funds? It's interesting, you know, I've worked in public health law for over 20 years, for close to 30 years now. And I get calls, and I've been receiving calls from health departments that, you know, don't necessarily know where this money is or how to access it. And one of the challenges with this money is that the funds, generally when a municipality gets funds, they're immediately placed in the municipality's general fund. That's by law. The money goes into a general fund, and then it can only get spent after it's appropriated by the city or town's legislative body. You know, so in towns, that's either town meeting or town council. Many towns have gone to the town council form of government because it's a little less burdensome than town meeting. So some towns have town councils. In cities, it's the city council that is the appropriating body. So receiving this money, you know, presents challenges for the municipality because they had to figure out a way to appropriate this money from the general fund to either free cash, or they had to create a stabilization fund and put the money, appropriate the money into that fund. Both of these approaches are challenging for different reasons, but the chief financial officer of a municipality, many of them were really stuck. You know, how do we actually do this, and how do we assure that once we do this, the money is appropriated appropriately? So, luckily, it took some time, but last month, the governor's supplemental budget called Chapter 77 of the Acts of 2023, amended Chapter 44, Section 53, which is how cities and towns appropriate money. And now the cities and towns can create a separate revenue account for what is determined to be periodic, non-recurring, unanticipated sums, as long as the director of accounts approves that. Now, who's the director of accounts? That is the director of accounts for the Division of Local Services. And I hate to get into the weeds on this, but for our purposes, all we need to know is that opioid settlement funds from FY 24 moving forward meet this definition. So the director of accounts has approved a city or town to create a separate revenue account. And once they create that revenue account, um, the chief executive officer, who is normally either the select board or the mayor, can spend those monies without further appropriation. So there's no town meeting involvement, no town council, no city account. The money just comes in to the town, and the comptroller or the chief financial officer puts it into a separate account that's controlled by the chief executive officer. Now, this is really good news because it's very efficient. But it's also challenging in that it's the CEO who determines how the funds are spent. And clearly there's guidance on how they are spent, and there are reporting requirements in order to assure that they're spent appropriately. But, it would behoove a city or town to put some sort of an advisory committee together, and make sure that the CEO has the information that he or she needs, in order to spend the money in accordance with the goals of the settlement. So just briefly, the public health excellence grants that I mentioned are a result of a special commission report, which was published in June of 2019. I was one of the members of that commission, and that commission actually looked at public health in Massachusetts, with a really critical eye, and came up with some strategies moving forward to really improve the efficient and effective and equitable delivery of public health services in Massachusetts. And one of our conclusions was that pooling resources, especially in cities and towns that don't have many resources, is a way to really expand the protections and opportunities that residents are receiving. So this is this grant program is a result of the special commission, and what happened was we never had a line item in local public health in the state budget until this blueprint was published and released. And now we have 321 of the 351 cities and towns in our state participating in one of these public health excellence grants. So what those grants are enabling is the promulgation of intermunicipal agreements, IMAs. And those agreements, they are authorized by the CEO, and they permit cities and towns to work together to jointly perform services and to share costs. So the goal of these grants is identical to the goal of the opioid settlement funds and abatement program, in that they are designed to supplement what's already happening in a city or town. So they don't replace your public health staff in your city or town, they would augment it. And again, that's one of the goals of the opioid abatement funds. So currently, what we have right now is MAHB provides legal education and technical assistance and works with city and town attorneys to draft these IMAs. And one option is for a existing public health excellence collaborative to add opioid abatement work to the work that they're already doing. And we do have some collaboratives that are looking into that. I know the Martha's Vineyard Collaborative is, and there are some in Metro West that are. The other option is to create a new IMA, a new collaborative that's only goal is to collaborate on opioid abatement strategies. So we do have two templates, and again, they're templates. They can be adjusted depending upon what you want to do and what you're able to do, but we do have them available. And I am done. I have not checked chat, so I'm going to stop there and see if there are any questions. and I'll stop sharing.
All right. Anybody have, I'm gonna check the chat for you. Anybody have question, Carol?
Thank you, Cheryl. Thank you. Thank you. Quick question. I appreciate all your work as one of those communities that has low capacity. I'm on the Board of Health. You mentioned the legislation. Many of our communities created warrant articles to create a special fund to get our funds out of the general fund. So the good news you said is that going forward in FY24, the opioid funds that were directly deposited in the town's general fund will now be able to be shifted to a special account. Is that right?
Correct. And I
By-
should, I'm sorry, Carol, I'm anticipating your question because I know you. And maybe I'm wrong, but I think what you're going to ask is what happens to the funds that are already in that stabilization fund? Is that correct?
Yep, but can you confirm going forward FY24, the funds come in to a town, the CEO or whomever by law has to move them to a special account. Is that right?
Yes, the comptroller, whatever that person is called, the
And
finance.
those funds don't expire. They can roll
Correct.
over. Okay.
Correct.
And yes, what's going on with the ones it started in FY22, right?
Right. So if you have created, and I didn't go through this, but this is also in the amended law, that if you have created a stabilization fund, you can vote to dispense with that stabilization fund, and the money will go directly into the new separate fund account. So it's a very easy process to get the money out of the current stabilization fund that was statutorily created and put into this new separate fund.
All right, there's a question in the chat that says, does treatment have to include MASH sober living?
No, someone else may know this answer better than I do, but any evidence-based strategies are permissible. I think that's the answer to that question.
Okay. And Mike added in there the 4 towns that are not part of the Excellence Collaborative. It's Waltham, Watertown, Woburn, and Marlborough. So if you're from one of those and you need help, you can reach out to Mike. And he's put his information in the chat. All right. I don't know if I missed anybody. Cheryl, thank you so much. That was really helpful.
Great.
And
Thank
if you don't mind, we'll share your contact.
Oh, absolutely.
info. You can change it, you can change your numbers immediately. And then it doesn't help. Thank you so much. All right. Moving on, and this is sort of how state of the art we are. You may have seen in the Boston Globe this week, there was an article about our next presenter, John King, who's from Andover. John is an electrician, and he developed a sensor to be used in restrooms that detects a lack of movement when somebody's using that restroom, and it helps to prevent overdoses. And so far, the system that he designed and he's installed has helped to prevent more than, this is a staggering number, 3,500 potentially fatal overdoses. And I did say 3,500, Karen's looking askance. So because we are so cutting edge here, and we're so fortunate to have so many people here from so many places that I feel like for people who come and present to us, it's really a pretty big stage, as we've seen. Those of you who were with us in the beginning, remember when we presented about the wastewater treatment, and then the pandemic came and they became famous. So I'm hoping the same will happen with John. But John, thanks so much for being here with us.
Yes, thanks for having me. I started the system. I designed the system for Boston Healthcare for the Homeless on Albany Street in 2017. And from there, we just expanded, and we did a lot of locations. We did some work for Boston Public Health. I designed a multi-stall system. I think it was 2019. And then we just kind of perfected that one, and that's for a multi-stall environment. We've used it for multiple rooms. And I always ask the clients how what type of facility they have. We've sold mainly the single bathroom system at different, over the country. What else do we do? We went down to Johns Hopkins in Baltimore and installed 5 systems for them. We've been doing it for a while. We've had really good success. I think we have some work currently going on West Street for Bridge Over Troubled Water. We've done a lot of systems, Newbury Street, Woman's Lunch Place, Rosie's Place. These are the places that we've installed ourselves, but we've shipped systems to different states. There's a 25 systems in Philadelphia. We sent one to Los Angeles for a needle exchange. We get calls all the time for different groups and stuff. So it's very rewarding work when I hear about that they save somebody, and I think it helps the clinics and the staff to be more relaxed and worrying about something happening in their bathrooms, and they're able to bring everyone back that the alarm went off, and they saved everybody for years now. We don't do any marketing. Most of our info is word of mouth or the media, and that's how you ended up finding me. There was we did a few interviews and stuff recently. The first one went out January 3rd. Within an hour, I get a call from a mother in Ohio. She lost a daughter from an overdose, and she was in the media for putting it out there on the obituary that, she died of an overdose, just to maybe help on another parent that not losing a kid from an overdose. But it's very interesting. So I've had really good luck with the system, and we're just taking the money that we make from the system and making it better and try to make it less expensive. But it works great.
So John, I go into a restroom that's equipped with your system, and a period of time passes and I haven't moved. The alarm's going to go off, right?
Yes. So if you're in a restroom that has a lot of overdoses, we'll shrink down that time. We'll do like less than 2 minutes. But if you do stop moving for that time that we set it ranges from 1 minute and 40 seconds to maybe 3 minutes. Yes, it will go off if you stop moving. We have these sensors adjusted so that you do micro movements. We do have false alarms because people stay still for, possibly 3 minutes. But we're trying to come up with a sensor, and I have some ideas to have a sensor that will sense the person and know that that person hasn't overdosed. Or right now we can only use movement. In the future, we'll have another sensor. It's going to be possibly a infrared sensor that watches the pixels of the body heat. You know, not an image of a person, but that sensor, I think, is going to be more finely tuned to detect that the person is still upright. They're making micro movements even smaller than the ones that we can see today. So the technology, it's only time and money. If I had plenty of money, I can do it quicker. If I don't have a lot of money to do the upgrades, it just takes longer. So, but the technology, I've been doing this for a few years now, so I get a good sense when I talk to the client in a facility. Like we sold a system for a tryout in a group in Connecticut, and they have, I think it's a methadone clinic. It's in Hartford, and they are rolling out the rest of their bathrooms. So once they tried it out and they liked it, it worked great for them. So it's it gets better every year.
I read in that story in the Globe that for some of the places, maybe like Pine Street or something like that, obviously people who are unhoused and, especially in the winter and it's hard to be out there, that sometimes the alarm goes off because they go into the bathroom and they literally just fall asleep. They're finally safe and
Yep.
warm and they fall asleep. So the downside being the alarm going off, but it certainly seems to be just from a humanity perspective and also from the people in the article, much better to respond to a false alarm than respond to an overdose.
Exactly.
Right. People have questions for John about the system, how that works, how to expand it into certain places. Sorry.
I have a question. John, thank you so much for joining us. I'm Alice Casey. I work here at Marion's office. So can you talk about when you first started this idea, the article referenced how you talked to doctors and nurses. Was there any, were people immediately on board with the idea? Was there some hesitancy? How did the idea sort of take traction?
So basically, Boston Healthcare for the Homeless, they had a lot of overdoses, or they still do, in their bathrooms. They didn't want to have any deaths. I had to come up with a plan that no matter what you did, the system was going to detect you from stop moving. The moving thing was the key thing. After talking to the doctors, once you overdose, there's no movement whatsoever. So that helped to design a system. The other thing that took the longest was, how do I turn on the system? And how do I know that the person left the bathroom? That took the longest. The simplest thing took the longest. So what we do is, typically bathroom doors are always closed. They have a door closer. The person enters, the door closes, and they use the facilities. They normally lock the door for privacy, obviously. So what we had to come up with was the idea of keeping the door open when the bathroom is unoccupied. And that is tough for people to wrap their heads around. But once they have that system in place and they're using it, everybody gets used to it. So that was one of the key things. The door is open when it's unoccupied.
How do they do that? How do they make sure that's the case?
Well, for the normal operation, we take the door closer and we can flip it to make it a door opener. So when the person opens the door has a tendency to stay open. So if they just grab the door, let it go, it's going to go back to the wall. And we also use a spring hinge. If it doesn't have a door closer, we'll take the hinges, load them in reverse, and as they leave, the door will swing open gently. But everyone gets used to it. It's the best way to go. We couldn't come up with any other design,
Yeah.
but it works.
John, what's the price range like for systems?
So for the single system, we've been selling it between 4,500 and 4,800 for all the equipment. And what we've been doing, some discounts will for multi systems will add in the shipping. We'll pay for the shipping. And then the installation for us to do it, there's other contractors, we'll work with another contractor and give them the rundown. When we do an installation, it runs between, depending on the circumstances and the distance, we're at about 4,500 to 5,000 for each room to install it. So it is, you know, it's not inexpensive, but it works. It's you know, we have some good luck with it. The multi-stall systems are pretty more involved. We just finished off Woods Mullen shelter on Mass Ave. That was a new construction, so we had the architect design the bathroom stalls so that they would work with our system. And they ended up with 22 bathroom stalls over there.
That's
Could
a
you
lot.
talk in a little bit more detail about the alarm goes off, like what happens? Is it the, you know, is it someone at the facility who will run down and check?
Yep. So basically, we have a keypad next to the door, and it tells you that the system is on. You can shut the system down if you like. If somebody, you know, the bathroom, the toilet's clogged or whatever, so you got to lock the door closed, so no, put it out of service. So you'd shut the system off with the key on the keypad. The keypad, normal operation. The door is open. You walk in, close the door. A light lights on the keypad saying the door is closed. You can actually look at the keypad and watch the motion. The motion light will go on and off depending on when the person is moving or not moving. So basically, if the motion stops, seeing motion, the light will go off, and then that's where the timer module starts. And if the person moves again, the timer is canceled. And then the cycle starts all over again. When the alarm gets, when the person stops moving, an alarm will go off at the end of the time setting. A chime strobe over the door will sound. So we had to come up with a sound that was different from any other sound that you would hear in a facility. And it's a chime noise that reminds me of like a train is coming. It will be like ding, 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 ding type of sound. So that was a key thing because we didn't want to have it sound like a fire alarm or a trouble signal or anything. And then the strobe, you can, at some places, if the bathroom is around the corner from first providers, most of our systems are in a clinic setting or hospital or shelter. We can add more chime strobes in other directions to direct them to the alarm. So the alarm goes off, whoever's in charge, sometimes it's security, they'll approach the bathroom, they'll knock, try to get a response. If they don't get a response, then they're going into the bathroom. At that point in time, upon discovery, and I've witnessed a couple of overdoses just by being in the building, and security would call for a code. They'll announce a code blue over the system, and then they'll respond. Everybody will come running, and then they have a crash cart handy, and then they'll bring the person back. Other facilities, it's usually the work is in the facilities, like you know, a healthcare clinic. So you always have doctors and nurses around. Everybody knows about the system, and then they might not have a paging system to call a code, but they're usually very close to the system. So we did a Duffy Clinic in Hyannis recently, and they have multiple levels, but all the clinic staff are on the same floor as the bathroom systems.
Oh, wow.
So they're all independent. The systems work as a standalone unit. If we're doing a multi room system that we recently did, Boston Healthcare for the homeless's respite area. They have 120 beds. They have 2 floors, and they have 25 bathrooms. And so we did all the bathrooms with the multi-stall system. We designed the system to do showers also. We have a special sensor that will go through the shower curtain and sense people taking a shower, moving and stuff without causing, years ago it was, well, we can do it, but you can't use the shower curtain. So it took us some time to find the sensor. We were initially putting the sensor in the shower, but with the moisture and the humidity and stuff, it wasn't an ideal environment. But we have another sensor that will go through the shower curtain, which works
Oh, wow.
great. Of course, it's more expensive,
Right.
but for the technology off the shelf, it was good. Eventually, I'll have my own design for the sensor to sense a lot better. It's just takes time. So, anyways, to finalize on your question, the chime noise and the strobe, they respond. There's people that respond regularly.
Okay.
People have asked me, well, John, why can't you put this in a Starbucks? Years ago, Starbucks, I had talked to them. They had called me about my system, and they just wanted no noise because they didn't want to disturb the customers. They wanted a light behind the counter that the baristas would go over to the bathroom, knock on the door, see if they're okay. And I was like, well, I don't think that's the best use of the system, but you know, they ended up not doing anything at all.
Hmm.
And they ended up closing their bathrooms. And
Wow.
I went to Central Square in Cambridge, and they had a death in their bathroom. It was at the time that I was developing the ability to mass produce it with instead of hand wiring, which was my first few systems, it was all on a printed circuit board card so that it was easy to manufacture. I approached the store manager, asked, hey, if I'll put in the system for free once I'm ready, would you be interested? At the time they were interested. When I was ready to install it, they had the bathrooms were closed.
Wow.
So after an alarm goes off, people respond, they'll knock on the door, and then once the door is open, you can press the reset button on the keypad.
Okay.
Nothing, you can't shut it down unless the door is open.
Okay.
So
Thank you.
sorry for the
Amazing.
long-
No, it's really amazing.
Yeah. Questions, other questions? All right, well, John, we will, as I said, this is a great group in spreading things around, and obviously our hope is that you get this to scale and it becomes more affordable for lots of people. Thank you so much.
Yep.
Thank you for being here. Thank you
Thank
for
you
the
for
work
having
on
me.
this. Thank you.
Great, thanks.
And our next presenter is Dr. Ranjani Paradise, who is a researcher at BU and the Director of Evaluation at the Institute for Community Health. And Dr. Paradise is going to talk to us this morning about the research that she and her colleagues have done at Mass and Cass on the key barriers and the challenges folks are facing to meeting their recovery goals. So, Doctor, thank you so much for being with us, and I'm going to turn it over to you.
Thank you, and thanks for having me today. And I'm sorry that I had a conflict earlier and missed the first part of the meeting. Just quick correction, I'm not actually with BU, but my collaborators on this study are, and I'm with the Institute for Community Health, as you said in the introduction. So let me just see if I can get my slides up, and then we'll get going.
Here we go.
All right, everyone seeing the slides?
Yep.
So as you already started to introduce, what I'm going to talk about today is some qualitative research that me and a team of collaborators in Boston did with overdose survivors who were unsheltered at the time that we spoke with them, really trying to just elevate some of their perspectives and recommendations about the experiences that they had with services and treatment and the things that they felt would be most important for improving their lives. So what I'm going to talk about today is a component of a larger study that's called the Boston Overdose Linkage to Treatment Study, or BOLTS. And I'll just give you a quick little bit of background on the big study and then jump into this sub portion really about unsheltered homelessness and opioid overdose. So BOLTS, the kind of parent study here, is a qualitative research study with an overall goal of understanding racial and ethnic inequities in access to treatment, specifically for opioid overdose survivors in Boston. And this all came about via an analysis several years ago that had found that Black and Latinx residents of Boston were less likely than their white counterparts to have received some form of substance use disorder treatment in the month following an opioid overdose. So that was really the motivator for this. And then this study, BOLTS, was designed as a qualitative follow-up to really speak with people that are going through this to understand what their experiences were and what was going on that was creating the trends that were coming out in some of the quantitative data sets. So this is a collaboration among my organization, Community Health, Research and Evaluation Organization, and we worked with Boston Public Health Commission, BMC, and the BU School of Public Health on this work funded by Rise Massachusetts Foundation. So with the full study here, we had 2 participant groups. I'm really only going to be talking about the overdose survivor component today. But for the overall study, we interviewed 59 overdose survivors. To qualify for this qualitative project, the participant had to be living in Boston, had to have survived an opioid overdose within 3 months of the time that we're speaking with them, and had to identify as Black, Latinx, or white. All of this data collection happened in 2021. So it's a few years ago now, but I think everything that you're going to hear will feel still very relevant to everything that is going on today. And most of the recruitment when we, for speaking with overdose survivors, we did most of that recruitment through the Engagement Center in the Massachusetts area. And as a function of that, we ended up speaking with primarily people who were experiencing homelessness. That wasn't something we necessarily set out to do with the original study, but just by virtue of the recruitment, that's what happened. So then in terms of the data collection tools, what I'll be showing is data from a demographic and drug use survey, and then most of it came from a qualitative interview exploring a range of topics. So now what I'm going to be really focusing in on today is a subcomponent of the full BOLTS study. So really what happened here is as we were going through the work and the analysis in 2021, the sort of ongoing crisis of homelessness and substance use disorder at the Massachusetts area was really escalating. And we were realizing that all the data that we had, all the conversations we had had with people were really relevant to that. And that although we hadn't designed the study with homelessness as a core thing we were trying to learn about, that was just really a central issue that a lot of people were raising or were tying together when they talked about their thoughts about substance use treatment or services that they were accessing. So we realized that it just, we had this opportunity that people had already given us time and shared their stories with us, and that it could be really useful to really do a sub-analysis for the subset of people that were living on the street at the time of the interview. So what we did was we did an analysis just for that set of people. It was 29 of our participants reported that they were living on the street at the time of the interview with us, and they were recruited in the Mass and Cass area. So we analyzed just that subset of 29, and that's what I'm going to talk about for the rest of the presentation. The goals of this sub-analysis were twofold. One was to understand and really elevate the perspectives and recommendations of this group of people. And the second goal, all of this was really in the hopes that this could help develop policies and practices that are responsive to the complex needs that people experiencing unsheltered homelessness who've experienced overdose are going through. So I'll just note that what I'm sharing today has been published in the International Journal of Drug Policy. So I'm happy to send both these slides and the paper to the group or to anyone who just wants to have the materials for reference later. So jumping right into some findings, I'm going to start just by sharing a little bit about the characteristics of the people we interviewed for the 29 participants that I'm going to focus on. So just a few selected data points from our survey just to give you a sense of the population and who these people were. So first, just our study design, we had sampled really deliberately to try and get a pretty equal distribution across racial and ethnic categories. So you can see, roughly a third of our participants identified as non-Hispanic Black, Latinx, and white. We found that most participants identified as male, and most of them were between the ages of 30 and 49. Of the folks in this sub-analysis, 2/3 of them had lived in Boston for at least 5 years, so they weren't, very new to the city. And then if you look at the social determinants characteristics on the right side, the criteria for this analysis was that the participant had to report living on the street, so that's everybody. We found that 79% of them had a history of incarceration and 93% were out of work or unable to work. So I think that just highlights that the people that we talked to here had pretty significant social vulnerabilities, and they were really at the intersection of multiple identities and experiences that are historically marginalized and underserved. Now, looking at health status and drug use. So first, I'll just draw attention to the fact that participants rated their physical health status a bit higher than their mental health status. And then in terms of drug use, almost everyone we interviewed had used opioids in the last month, and almost everybody reported using stimulants in the last month. So for this particular population, polysubstance use was very common. And almost everybody had experienced multiple overdoses in the last year. So to qualify for the study, everybody had to have experienced an overdose in the past 3 months, but for most people, this wasn't their first overdose. Most of them had experienced several in the last year. So I'm going to go right into some of the qualitative themes at this point. I'm in 3 main categories. First, what people had to say about housing resources and services. Then their experiences living in the Mass and Cass area more broadly. And then third, the recommendations that they shared about the things that they thought would be most helpful. So with housing, first, people spoke about just a shortage of affordable housing resources. Again, this was in 2021, so there has been ongoing work since then, but at the time we were talking to people, really just talking about not having enough options, and then even when trying to access the resources that existed, that long wait time sometimes just reduced their confidence in the system being able to get them housed. Some people talked about how housing searches are just really energy intensive. And I think for this particular group of people who are focused on day-to-day survival needs and safety, sometimes that extra energy required to go through the application process was just felt too much for people. And then a couple people highlighted that even when they did get housing placements, sometimes they just weren't meeting their needs. We actually had, I think, 2 participants that talked about turning down a housing placement and choosing to stay living on the street because the location of where they got housing was too far away from Boston, where their networks and resources were located. People also talked about how the residential treatment continuum for substance use disorder can be a pathway to housing. but that they often experienced a shortage of beds in trying to get into a treatment program, especially in the wintertime when some people are accessing treatment specifically to have a place to be, a place to be safe and spend the night. People also talked about the fact that although going through this continuum can result in something like a sober living situation, that the system itself is fragmented. So there can be gaps in between different components of that continuum that leave people sometimes, back with no place to live while they're waiting to get their bed in the next program. A lot of the participants here also talked about the local emergency shelters, which they really were just seeing as not a viable alternative to living on the street. And I'll acknowledge here, of course, we're analyzing a group of people that were choosing to live on the street. So this may not be reflective of everybody, but for this group of people, they were specifically choosing living on the street over the shelters. A lot of folks talked about feeling like the shelters, they would use words like dirty or stinky, saying they didn't feel like they were clean or sanitary enough. Some felt that there wasn't enough privacy or that they were concerned about safety. This was really, early on in the COVID pandemic. We didn't think it was early on at that point, but now looking back, it was. So there was also some fear about COVID transmission in the shelters. And then a lot of people highlighted feeling like the staff were treating them disrespectfully. I'll just make a note of the quote here in the green box that this person likens the treatment from staff in the shelters to jail. And then finally, just, in terms of alternatives to the shelter system, places that people felt like they could go to feel safe and access some basic resources. There were a lot of positive experiences with the Engagement Center specifically, and some similar programs like Project Trust, which is also nearby. Folks talking about how they preferred to go to those places over the shelters, talking about things like the treatment from staff, feeling like the staff really cared about them, would notice what was going on, engage, like do what they could to help, that they had some just like the quote in the white here, just access to some services, showers, things that just helped them meet basic needs, that they felt comfortable and safe and welcome in environments like the Engagement Center. So next, moving on to just the more general perspectives about what it was like living at Mass and Cass, participants talked about just a feeling of kind of chaos and instability and insecurity living on the street. And, this was, even though they were talking about preferring to live on the street over the shelters, they still described this, sense of not a lack of safety and instability that came with this environment. Some people talked about violence and theft that they, felt were just kind of part of life for them. People talked about the fact that there was a consistent police presence at Mass and Cass, but the perception was that the police weren't necessarily there for the purposes of protecting safety and well-being in a day-to-day way. So in the quote here in the green, this is an example of the type of thing people would say, just that they felt that although there were police around, those weren't necessarily the people that were that they were perceiving to be out there kind of reversing overdoses and helping with those health needs, that it was the Engagement Center or the local nurses that, as this person describes, kind of flying back and forth, giving Narcan, giving meds. And we also heard a really, I think, interesting, nuanced and mixed set of perspectives about the public drug use in the area. So people talking about both benefits and challenges to living near this kind of public drug scene. So one thing that came out was that people had a certain sense of safety, actually. In the last slide, I was talking about some of the lack of safety people felt due to violence and theft. But at the same time, they would talk about having a sense of safety because they felt that if they stayed in that area, they were safe from dying of an overdose because there was just a concentration of community members and staff around who could administer naloxone. And that was really important, a reason that people felt that they could kind of take a breath and feel safe in this area. Some talked about just appreciating just the concentration of local resources and services that were available for when people needed them. And then some people on the other side talked more about the challenges here of feeling like being around so much drug use was a barrier for people who were seeking recovery, or might be something that was attracting people to the encampments rather than helping to address homelessness more broadly. And then I just want to talk through a few of the recommendations that people gave. So they're in a few different categories. The first was around expansion of housing and related resources for social needs. So people really talked about how they needed just more access to affordable and supportive housing for more permanent situations, but also the local shelters. They talked about the improvements they would like to see to make those more of a viable place to stay. And then some people also highlighted other social needs that just related to their ability to stabilize and be able to stay housed if they were to get housed. Things like access to employment, educational opportunities, and then for people thinking more about their day-to-day without permanent housing, talking about kind of a need for more of sanitation services, access to bathrooms, things like that. You know, a core component of our study, as I said at the beginning, although we heard a lot about the experience of homelessness and perspectives on housing, a lot of what we were really trying to learn about was substance use disorder treatment and what could be done to help make it more accessible and something that people wanted to engage in. So that also was a theme that came through from this participant subgroup. People talked about really noting that the stigma in treatment settings really needed to be addressed. They recommended that program staff should ideally reflect that the program staff themselves should have lived experience with addiction and homelessness, or at least be a type of people who could relate and empathize with that experience. The people also talked about treatment programs. They felt like they were rigid and a kind of one-size-fits-all approach rather than being customized to individual goals and individual preferences and needs. And then the other sort of concrete category of recommendations here is people wanted to see an expanded availability and more access to harm reduction resources in different settings. There was a lot of appreciation for places like the engagement center, harm reduction oriented programs that were drop-in and low threshold, and people wanted to see that type of approach and those types of resources available in more places. Some people specifically recommending indoor overdose prevention sites. In this quote here, this person is talking about the engagement center, really highlighting how they see it as a really amazing place. And one thing they talk about here is just highlighting just how incredibly effective it is at keeping people alive. And they say there's been 0 people who have died here. Imagine how many people would have died, you know, if the nurses weren't running around and Narcaning people. And they also, in this quote, this person also talks about that the engagement center and places like that also serve as a linkage for folks who do want to move into getting medication for their opioid use disorder or entering a residential treatment program, that can be the point of connection for them. And then the final recommendation here is sort of zooming out a bit. It's really just to include perspectives like this in policy and program design. People just talked about how important it is that people like them, people who have experienced overdose and homelessness, get to be involved in developing the solutions that can best meet their needs. So, you know, talking about how they wanted to see policymakers come to the area, talk to them, learn from them, and then go and, you know, take action based on that. And that, you know, involving people who are experiencing homelessness or people who have experienced overdose in policy solutions. So last thing here, I'm going a bit quick because I know we're short on time. I just compiled a list of the things that the that really these findings from this group of people really call for. This is just kind of a summarizing of the various suggestions on the previous slides. So I think I'm not going to read them all now. I'm, again, happy to share this deck with everybody. So what I'll do is I'll just do a couple quick acknowledgements, and then I can take questions for a couple minutes. So just want to make sure to take a minute here to first just really acknowledge all of the study participants that really make this all possible, that gave a lot of time. I shared a lot of stories with us and contributed their expertise in helping our research team learn from their experiences. Our study team, I want to make sure everyone gets acknowledged. This was a big group effort across multiple institutions, and everyone here had a big role in making this happen. Finally, just the funding acknowledgement from RISE Massachusetts, as well as some additional grant support for 2 of our collaborators at BMC and BU. So I'm happy to take questions if there are any in the last couple minutes. I will turn off the screen share, but if anyone wants me to pull something up, I can do that.
Thank you, Doctor. That was great. Questions? See. Just we have a note in the chat, just noting how helpful it is to get the lived perspective from the street.
I have a question.
Sure, John, go ahead.
The engagement center is the new one that the city of Boston built in the Mass Cass area. It's behind 112 Southampton Street. Is that correct?
Yes, except when we were doing the interviews, it was before the new engagement center.
Oh,
yeah.
okay.
So it was just
All
kind
right.
of like a mostly just tented area at that time, but the new one was in the works.
So while they were building the engagement center, they had everybody out in the parking lot.
Yeah, there was
And-
some indoor space availability, but it was mostly outside. We were talking to everybody outside. So the bigger structure was not available yet. People knew about it though. It was coming.
So I talked to some of the providers and I asked them, you know, how often do you get overdoses in this area? And they would say, we could have 2 or 3 at the same time.
Mhm.
And I thought it was kind of interesting because they were passing out needles and packets and to do a clean injection and stuff. But when you're there out in the street, it's unbelievable what you see and stuff. I mean, I've spent a lot of time with the homeless, in that area. And yeah, I connect with them, I think. I ran into a friend of mine that was homeless at the shelter at Boston Healthcare for the Homeless because I spent so much time there. But it is nothing that I've ever seen anywhere else I've been. But they've cleaned it up a lot. They've done a lot of things. The engagement center, I have systems in the engagement center and stuff. They've done a lot, I think. Recently cleaning up the street and stuff and keeping track and try to get people housing. I talked to one woman at one of the shelters. I just saw her yesterday, and she was at healthcare for the homeless being treated. She just got a voucher for housing. I go, well, what happened? She says, oh, I made the appointment that wasn't available. And then she's going back. And then she lost her phone. Then she got a new one. So I just wanted to say that pretty quick because I'm all in. I understand how certain things go with the homeless group and stuff. It's very challenging for them. And that was an interesting report. I'm glad I was able to see it. Thank you.
Thank you.
Thanks, John.
And
We had
there's been a lot
question.
of great, I just want to make one quick note to your point. There's been a lot of great work that, it was up and running shortly after the time of our study around low threshold housing and pathways to housing for this exact population that I think align really well with exactly what people were asking for. So that's been great to see.
There's a question in the chat about whether the participants were compensated, and they did get a $50 gift card for participating in the study. Any other questions? All right. Thank you. This was fascinating. Thank you, doctor. Thank you so much for making time to be with us. Thank you. All right. We've certainly had an information packed meeting. I want to give people a second if anybody has information they want to update the group on, anything that's going on that you want to let people know about. And if not, I ask you just to think before our next meeting about the question I posed at the beginning. We're seeing that uptick in suicides and just what you're seeing in your work. Places where you think we might be helpful, things we need to talk about, anything that you are seeing or thinking about in that area. Because as I said, you know, there is that urgency. Our goal is to get that number down for the first time in a decade, below 150 this year. And that is also going to include a lot of work on the suicides. So again, thank you to all of our presenters for being here. Thank you to Madeline and Alice for putting things together. And thank you all for making time in your busy day to be